I just wanted to say that the best way to get information about what's happening in the world of Kokua Mau with our movement to improve care is to get our newsletters. We're now going to shift into the presentation for today. And we have five of our colleagues are going to speak today, and I'm just going to do a short bio, and then we're going to launch into the slides. Okay, so Laura Arcibal is an MPA, and she is the State Telehealth and Health Access Coordinator at the Department of Health and the Office of Planning, Policy, and Program Development. She's a 10-year veteran employee of the department, starting her public health career under the former state epidemiologist, Dr. Paul Effler, administrating the Hospital Preparedness Program. Laura is a proud Native Hawaiian raised in Fairfield, California, Kwajalein in Marshall Islands, and Windward, Oahu. She earned her undergraduate degree in biology and graduate degree at the University of Hawaii. Michelle Cantillo is the Advanced Care Planning Coordinator for Hawaii Pacific Health. She has oversight responsibility for the development of advanced care planning programs at Kapiolani Women's and Children's, Palimomi Medical Center, Straub Medical Center, and Wilcox Medical Center. Michelle is the instructor for all the advanced care planning classes for patients, clinicians, and the community, and helps to support the palliative care team. Her role also involves supporting patients requesting medical aid in dying and helping Hawaii Pacific Health providers and staff through the processes. Prior to working as an advanced care planning coordinator, Michelle practiced for 30 plus years in nursing, primarily in critical care. Michelle was an ICU supervisor and manager for 12 years before transferring to HPH's Patient and Safety Quality Services in 2011 under her current role. Erin Hamilton is the Area Director for Bristol Healthcare Services. She's been working in healthcare for the last 13 years and in hospice for 9. She is the Director for Community Development and serves as an internal and external navigator and consultant for Bristol and the Our Care, Our Choice Act. Jodi Shaw is an oncology social worker for Kaiser, Permanente, Hawaii, and one of 2 patient care coordinators for the medical aid in dying option. She's board certified in oncology social work and advanced hospice and palliative care social work. Jodi has worked with patients with life-threatening illnesses for 19 years, first at HMSA and as a palliative care case coordinator or care coordinator case manager, and since 2008 at Kaiser as a palliative care social worker in the home, inpatient, and clinic settings before becoming Kaiser Hawaii's first oncology social worker in 2010. And then Karen Ireland, who is an independent consultant. She had a 35-year career in healthcare leadership and management, including at HMSA on quality and health improvement programs for members and providers. She retired and started her own consulting company in 2018, and she currently works with Compassionate Choices to organize clinical education, consultation, and relationship building with the medical community regarding the implementation of the Our Care, Our Choice Act. She helps to coordinate high-level discussions with key stakeholders and works with multiple entities to provide balanced information to audiences. So thank you again to everyone for coming today. I'm really looking forward to it.
Okay, mahalo, and thank you for having me, Jeanette, and everyone here. It's nice to see you all here. For having me to present on behalf of the Department of Health. Our role in medical aid and dying is to collect and report on the data to Hawaii's legislature annually on or before July 1. The data that we do collect is on patients who received a prescription. I'm going to be providing a general basics of the requirements of the law, and then go into providing data collected from the past 2 years since the law began on January 1, 2019. And then I'll highlight the forms and tools that assist providers in documenting and collecting the data, and then wrap up with the recommendations that the department will be providing for the 2020 legislative report, which is the same as 2019. So medical aid in dying is a medical practice. It's in which a mentally capable adult with 6 months or less to live can request a prescription for medical aid in dying from a doctor to end their life and suffering. This slide is a list of end-of-life options that are available for patients. And as you can see here, medical aid in dying is one of the options. I would like to just note here amongst many of the hospice folks that are on here already who are familiar with this list, that the majority of patients are hospice patients that are participating in MAID. Medical aid in dying eligibility requirements are that the patient must be an adult and a resident of Hawaii. They must be terminally ill with at least 6 months or less to live, to have mentally capable of making an informed medical decision and able to self-ingest the medication. The patient must make at least 2 oral requests 20 days apart with an attending physician. The first oral request can be documented in the medical record and used by another physician. The attending physician makes a referral to a consulting physician as well as a mental health provider. And then the patient provides a written request that is signed by 2 witnesses, of which one is unrelated and cannot be a healthcare team member as a witness. The healthcare team member cannot be a witness on the patient's written request form. So there are 3 providers that are primarily involved in the medical aid and dying process. That is the prescribing physician, which we refer to as the attending provider, who evaluates the patient, documents the oral requests in the medical record, and as well as the forms, follows the compliance process and prescribes the medication. And there's also a consulting physician who confirms what the attending provider's assessment is of the patient. And then there's a third, which is unique to Hawaii, is a mental health provider who can be a psychiatrist, a psychologist, or a licensed clinical social worker. And they would be responsible for evaluating the mental capacity of the patient to make an informed medical decision. Okay, now we're going to go into updating of the data that's been collected over the past 2 years. So this is a summary. I do close the data for collection received and post-dated by December 31st of every year. And for 2 years, there's been a total of 67 patients who received a prescription. Those patients are qualified. Of those patients for 2 years, 39 ingested medical aid in dying. So for 2019, 15 ingested, as well as 23 patients who received a prescription. And then in 2020, 24 patients ingested the medication compared to 31 patients who died in 2020 and received a prescription. The average number of days, we've been tracking this mainly for understanding of the time it takes for a patient to make a request, a first oral request, to the time a patient received a prescription. And the average number of days for 2019 was 35 and 45 for 2020. And the most cited underlying condition for patients receiving MAID is cancer. A majority of the patients, as I mentioned before, are hospice patients over the age 65, receiving private insurance. They're white and male. This is the other data. Some of this data, let's see, is a part of the previous slide that I talked about. This is reported and shared by Kaiser as well as Hawaii Pacific Health. This is 166 total referrals. This also goes into apparently 2021. So this is not just 2019 and 2020, but also includes 3 months into 2021. You could see here that the number of referrals is much higher than the number of patients that are reported to the Department of Health. And just a review of some of the findings that we're seeing within the department is that access based on the data still remains a challenge for the neighbor islands patients, and we're going to come to that slide coming up. The attending physician can retain the final attestation form. The Department of Health does not need a copy, but you can certainly send a copy to the department for sure if it's received. We're asking that providers collect all the forms and submit it in one report. So that is on the Department of Health's website. This is the 3 provider forms as well as the patient's written requests. That combined is report 1. The only form that comes in report 2, if the attending physician is notified of the patient's death, is the follow-up form, and that's all that makes up report number 2. We're requesting that providers not send them in piecemeal because they are, that can be unwieldy in terms of tracking and recording the patient information. Again, to make sure that physicians indicate on the death certificate the underlying illness. We've had several times within the Department of Health where the provider indicated suicide by medication and some other underlying illness for the cause of death. And we've been able to have our vital records office inform us, and then we would have to go back to the provider to make the changes. We encourage providers to continue training to increase awareness about the medical aid in dying process. And then there are resources within the Department of Health on the website. If you just Google Our Care, Our Choice, Hawaii pops up, and our website is there. The forms are downloadable and providers can complete the forms and follow the tools that are available there. Again, Hawaii is the only state that requires a 3rd mental health evaluation, and that we've had requests for patients and providers to talk about this first oral request. So for clarification, patients could have an attending provider after making their first oral request with the initial attending provider. What that means really is that if a patient comes to a provider and the provider decides to opt out and documents that first oral request in the medical record, that attending provider who ultimately writes the prescription can utilize that date as the first oral request date. It just must be documented in the medical record. We've combined so these are the number of providers that participate in the islands, and you could see I've titled it patient access because if there aren't any patients on the island to do medical aid in dying, then access is a problem for patients. So this is about patient access, this slide, and you could see the majority of attending providers, consulting providers, as well as mental health providers are all on Oahu. Overwhelmingly. So neighbor island access is limited. And then the department's recommendations it remains the same for 2019 and 2020. The waiver of any waiting periods if the attending provider and consulting provider agree that patient death is likely prior to the end of the waiting period. And then also given access is limited to healthcare providers, the DOH recommends that we authorize advanced practice registered nurses to serve as attending providers for patients seeking medical aid in dying. I'd like to highlight here what is not in the DOH report. Is the number of patients who died during the process from the first oral request to before receiving the prescription. those patients that are ineligible, and then again, total number of patients accessing MAID. We do not know that. This is documented in the provider the patient's medical record with the provider. Again, we only collect data on qualified patients who received a prescription. I'll touch upon the forms that were vetted by the Medical Aid in Dying Board. Again, these forms were designed to guide the provider and the patient in answering all the required questions that are around medical aid in dying. It documents the process to ensure that the provider and patient meets the requirements of the law. And then it collects the data that is reportable to the legislature every year, due on or before July 1. This is a really great tool that came about through the vetting process. It goes through from day one of the first oral request all the way up until the prescription, and then days following the written prescription. So I'd highly recommend providers who are going to participate in medical aid in dying, or just to familiarize yourself with the process, please take a look at this timeline eligibility process form. And then there's links to the required forms providers would have to submit to the Department of Health. Again, this is a list of the forms that are required. It has the 3 provider forms as well as the patient's written request. They're all downloadable off of the Department of Health's website. So those 4 documents are submitted as report number 1, 30 days from the written prescription. And then upon notification of the patient's death, the attending provider would complete the follow-up form and then submit that to the Department of Health within 30 days. And that would complete report number 2. This is the attending physician's report. This is important because it captures the diagnoses and the prognosis of the patient, 6 months or less to live, terminally ill, and the provider would indicate that on the provider form, as well as capture information about the patient, the first and second oral requests, as well as the medication that was prescribed, and also indicate the dates and names of the referrals to the other 2 physicians. So the consulting physician, as well as the mental health provider, is documented on this form. The attending provider will sign it and attach the other 2 providers' forms, as well as the patient's written request, and that gets submitted to the department. And all the information is there, tells you when to submit it within 30 calendar days. Next slide. Thank you. Thank you, everyone.
Thanks so much, Laura. And thank you, Laura. She's a great resource to myself and Susan. So I'm Jodi, and I'm the oncology social worker at Kaiser, and one of 2 patient coordinators for the MAID option at Kaiser. And my counterpart is Susan Amina, who's an APRN here at Kaiser. And I'm so excited and to be here today with Kōkua Mau and all of you. I got my start really in this work, through Kōkua Mau or at HMSA, and I first joined Kōkua Mau, I think it was in 2002, when we would meet at HMSA at 7 a.m. And thankful to I see my old boss is on here, Melissa from HMSA. So nice to see all of you on here. So I'll be going over, how we do it at Kaiser. And so basically, Susan and I are navigators for the patients and the families, and we walk them through, all of the steps and the forms. We get all of the appointments with the providers scheduled for them, and we also help to walk the providers themselves, through the process if needed, especially if it's the first time that a provider is participating in the process. Next slide, please. So how it all starts at Kaiser is if a patient is interested in the medical aid in dying option, then they should talk to one of their providers. So it could be their PCP, it could be their specialist, like their oncologist. And if the doctor feels that they meet the basic criteria, then they put in a referral in Health Connect, which would come to Susan and myself. And then once we get the referral, then Susan and I would, we take turns on the referrals, and we contact the patient and their family, right away or as soon as possible, and set up a meeting with them. It could be in the office, say they're here in oncology, they'll come over and see me after the oncologist, or it could be over the phone, also, by video as well. But we really, do like that initial patient coordinator meeting to be in person or by video, if at all possible, because we really take that opportunity to try to, really get to know the patient and what is motivating them to consider this option, and making sure that, they've looked at all the different options. And we always encourage hospice hand in hand, with this option. And I just want to say thank you, to the hospices. We work so closely with all of them, and I feel, they're such an important part of the team to support, these MAID patients and all of our patients. And we couldn't, do it without them. So, again, it's when we first meet them, just trying to assess different things, their supports, and just exploring everything and what's most important to them, what their goals are. And then we go into detail as far as, the process. And we'll see this later on, but we do have a MAID guidebook that Kaiser's created. And on the back page, there's like a checklist that lists all the different steps where they can write in the dates and then check it off, and, just to make it really clear. But we always just, stress that Susan and I will walk them through this. And we're very mindful of the time frames and try to do it as quickly as possible for them. So again, we do set up the appointments, and of course, providing support, emotional support in a compassionate and non-judgmental manner. So not only to the patient, but also to the whole family. And I would say that we really get to know, a lot of these spouses very well, or family members, and really helping them through this as well. I see so many, very supportive family members that are supporting their loved one in this process, but they have such mixed feelings with it too. And they're, already starting to grieve. And so a lot of it too is supporting the family as well. And then of course, keeping the different providers informed as we go along the process, the PCP, the specialist, and if someone is on hospice, also keeping them updated where they are in the process as well. We do have a tracking system through a database that Susan and I keep, that helps us to keep track of everything. And if one of us is out, we can always refer to that database. Okay. And so, as far as scheduling the appointments, we actually really, try to schedule the appointments as soon as possible. So a lot of times we're able to schedule them, I'd say within a week or within a week and a half or so. And I think it gives the patient and family peace of mind also, knowing that it's all set up and all, it's going to happen quickly. But then they still, have to wait those 20 days between the first and second verbal. And we give them the different Department of Health forms, and, remind them that once they meet the third provider, then they can complete that written request. So when I send the patients the forms or give them the forms, I put like little sticky notes on the form. So, complete after meeting all three providers, make sure the dates are all the same, for the witnesses and the patient, but just, little notes and tidbits here and there to help them, because they're dealing with so many things. So we want to get that written request back as soon as we can, because there's two time requirements that are required. So once we get the written request, we have to wait 48 hours, by law, before a patient can give the second verbal request. And then also in addition to waiting those 20 days between the first and second. So we love to get the written request, as soon as possible, so we don't have to worry about that, that piece of the process, especially if the patient wants to get the medication quickly. And then at Kaiser, they return all of the forms to the navigators, and we check the forms for accuracy and completeness. And then once the prescriptions are written, we would send it all together to the Department of Health. So we're on the next slide, we'll see. So Kaiser was, really great, and before the law came into effect, they created a lot of templates for all of the different providers. So there's a template for the providers, and for all of the physicians that are involved, so attending, consulting, mental health provider, as well as just when a doctor makes the referral to us, there's also a template. And it's really good. It walks the doctor through the different requirements and steps and what needs to be covered. And then, we often are making hospice referrals for these patients. So that would be, documented, as well. And then Susan and I, even once a person finishes the process, we follow up, with phone calls and checking in with the patient and family, but also with, reminder calls and, throughout the process, and just walking them through step by step. Next slide, please. So this is, for example, our template for the coordinator, evaluation, or when we first meet with them. This is our FAQ sheet for patients. So it's right on our Kaiser Health Connect homepage. So, any staff member could give this out. So if a patient asks about it, this can be given out to patients. And, so staff shouldn't, have qualms. We all have different feelings about this, and they can just give patients this, and they don't have to discuss it, especially if they're not comfortable. And but the main thing is that they should talk to their physician, if they are interested. This is our, this is the cover of our guidebook, and it talks about, the process, about palliative care, about hospice, and then again on the back page is the checklist, the patient checklist. And let me mention too that we also have a provider FAQ sheet that we have on Health Connect for providers with more details. Next slide, please. So let me just share real quick one of our patient stories. So Betty was a 76-year-old woman, and just very vibrant and full of life. And she was unfortunately diagnosed with ALS, and it actually, she began to decline very quickly and became unable to do, more and more things for herself, and more dependent on her family. Very loving husband. They've been together for over 50 years, 3 children, just, loving family and friends. And, for Betty, she knew that she didn't want, she wanted quality of life, and she didn't want to be a burden on her family, and she didn't want to live, in the state that it looks like it was leading toward. So she decided to pursue this option, and then she went through the process pretty quickly, and her family just rallied around her. And her children who live on the mainland, they all flew in with their families. So this is pre-COVID, and I think their house was filled with maybe 15 family members, and a lot of friends were coming, and it became, for her a celebration of life prior to her taking the medication. She always liked to also be in control and have options. And so for her, this was her choice. And her family supported her in this. And she requested that a certain song by Hapa be played as she took the medication and at her funeral. And her husband was just amazing and just supported her in all he did. And when I asked him how he was doing, he said, I'm just focused on her right now and making this happen for her. And she actually took the medication on her birthday. Um, and but it was just such a powerful experience, and I feel like it was a privilege to be a part of, but for her it was what she wanted, and she's just thankful that it was now an option for her. So just really quickly, so just kind of looking at some of the changes and developments that have happened at Kaiser from when we started in 2019 to present. So prior to the law going into effect, there was all these different departments, and they put together, different workflows and processes and templates. And definitely the time from referral to dispensing of the medication has decreased. We've, improved and built upon our partnerships and working relationship with the hospices, and so thankful for all they do. There's been an increase in the number of doctors that participate at Kaiser, and even on the neighbor islands as well. And for the medications, previously we weren't doing compounded medications, and we worked with Jake at Elix RX, and we're so thankful to him. But we now are able to dispense the medication through the Honolulu Kaiser pharmacy, as well as on the neighbor islands. So previously it was only, through Jake, and our patients had to fly over, or their family members. But now there are dispensing sites on, all of the islands where we have clinics. We've also moved from DDMP2 as the medications to DDMA. Quest, it became a benefit, so we've created a workflow for that. And maybe just, one of the challenges, and I think for all of us, is that sometimes the timing of the referrals is a bit late in the game. And we just, try to keep educating, our providers and staff to please let us know, or please encourage the patients to reach out, or tell them about the process so that we can meet them sooner and help them sooner in the process. Okay, I think that's for me. Thank you, everybody.
Thank you, Jodi. That was awesome. Much of what I'm going to say is are very repetitive of what Jodi and Susan does over Kaiser Permanente. We do it just a little differently, but basically it's about the same. So I'll go through that process. Again, my name is Michelle Cantillo, Advanced Care Planner at Hawaii Pacific Health, and I've been in this role for the last 12 years now. And I've been with Kokua Mau since 2006. Really got involved with them way back for palliative care when I was in the ICU. All right, so my role as a coordinator is to coordinate throughout our system, our 4 hospitals, making sure the education is done, making sure the providers know what medical aid is dying. There's constant PCPs coming in and out, so I have to put that on my list to reconnect with them. I am the resource for HPH for medical aid in dying. So people have questions, they'll reach out to me. I do all the data for them, and any processes that needs improving on the flow of medical aid in dying, it kind of goes through me. Like I mentioned before, I do all the education as well for medical aid in dying. It's also in my advanced care planning classes. I've had to include it since 2019. And not only do I do education on medical aid in dying for our HPH staff, but I also do it for other providers, independent physicians that says, oh, I need help with this. For example, in Kauai, I've had some consulting physicians. In Maui, I've had a attending physician who their patient was with us through their oncologist or through their PCP, wanted to do it, wanted to know. And I was there to say, hey, I'll follow you, I'll help you through, let's do this together. So that's my role. I'm also behind the scenes for working with the oncology staff and the doctors. Communicating with them, making sure that we did all the timeline, making sure Laura, Department of Health, gets all our forms just realizing, oh, one of the independent docs back in Kauai didn't put in his form. So it's like you have to nag some of these patients that I'm not patients, docs who are independent. Otherwise, I'm a family resource, patient and family resource. I find with the outer island patients, I really connect with them a lot. And so they have my speed dial. If anything is needed, they have me as a resource as well. And not only am I here for our staff at HPH and other independent docs, etc., I'm here for you guys, for the community as well. And that's why we're doing this, you know, to help, no, not to be scared, learn, understand. And our biggest thing is to support our patients and how could we do this together as a community. So again, Kōkua Mau has always been very helpful with any kind of end of life processes, advanced care planning, etc. And I am the one responsible for when we have debriefing cases for medical aid and dying as well. Next slide. So referrals can come in either from the provider. I say a majority of our referrals come from PCP and or oncologists, as 80% of our patients are oncology patients. They'll either go to the social worker, to the nurse navigator, or to myself, or we'll all get an in-basket message together. For the patients who are not oncology patients, for example, the PCP will set for frail elderly, they'll contact me. And then the ALS patients, they'll contact me. So the team will determine who will be the attending, who will be the prescribing physician. Again, not all PCPs are comfortable, so we'll check in with them. Hey, okay, if you don't want to be the attending physician, here's what the consultant's role is, and educate them on the process. I have an independent physician in Kauai who 2 or 3 times I've gone over to her office. I've done education for her, and she has referred patients for medical aid in dying through Hawaii Pacific Health. And she's like, I'm not quite ready yet, Michelle. I'm not quite ready, but I'll be the consulting physician. Give the providers their own time and space too. Everybody's got to do it in their own space. We do, for some of our patients, we do offer palliative care optional as well, done on outpatient. We have set up outpatient palliative care services for the oncology team, as well as for the geriatric team. So about 50% of our patients have had a palliative care consult. Education appointment, so much like what Jodi and Susie do is just sit down with the patient. For me, mostly for me on my end, when I do it, it's a lot of through Zoom or telephone. And then obviously for the nurse navigators and the social workers, they're right there. So goals of care discussion, the whys, what's important to them, like Jodi mentioned, their fears, their worries, spiritual, what's important to them. You know, we start doing about advanced care planning. Many patients, they haven't even started the process. So we get them up to speed. And then of course, review the law. And once we've kind of gone through the reason for requests, and many times it's basically, I want to have this end of life option, or I'm declining and I want to have this option. And then once all those are kind of done and we explore the values, the processes, and ideally I like to have the family or their support person as present as well. Then what's your next steps? Check with the patient. Do they want to proceed? Last week I had a patient, I went through everything. She was in her 90s in Kauai, went through everything. And then she's like, Michelle, I'm still having fun. I'm still playing bridge. She plays bridge in her nurse. It's not an independent living by herself. And she beats her friends. And then she's like, I think I'm good right now, but thank you for educating me. I'm going to keep it at the back of my head. So really check in. Whereas another patient says, Michelle, as soon as I finish this process, I want that medication in my hand. So everybody's different. A lot of people on the first meeting will ask about the medication, what's involved, the compounded medication. So I don't give them the full detail. I'll say, here's what's involved, what's the medication, just as a start, because they need to know how does it work. And then later on, whether it be me or the nurse navigator or the doctor, then we'll then go through and say, hey, let's set up a separate meeting and let's go through the medication, that process, and who's going to help you through it. And I always, I do a next steps with them. So a lot of my communication with some of my patients, whether by telephone, is also by email. And I'll say, okay, we've done this. I need the written request here. Here's your next steps, A, B, and C. And then they're like, oh, I need to do this. And they're pretty good. And usually it's through with their family members. So our roles, all you guys in this room today are patients advocates. That's why you're here at Kōkua Mau. We are there to support them. Again, you're here, be open, be aware of your biases, how you feel with this, regardless, be non-judgmental. And we're here as healthcare professionals to provide information to them in a neutral manner. And continue to educate your colleagues as well. You know, if they don't understand what it is, that's your role as well. As Jodi mentioned before, again, if their timeline is declining, we need to make those appointments for us. And we try to make those appointments within 2-week time period. And then the other stuff, the psychosocial assessment, the ACP, the hospice, and the coordination is all there. And definitely for the staff as well. And then Linda, I saw you have a question, but we'll answer questions after all then. Thanks. One of the logistics I'm gonna say is the medication part. Sometimes we think, okay, the physicians write the prescription, it's all in there. For us, it's in our Epic, we could print it and things like that. But many times it's the people right there. So for us, it's our social worker that really kind of makes sure everything is done right and sent out. When Jodi mentions Jake is actually, it's the Elex prescription pharmacy in Kailo, and that's where most of our medications in Oahu for us comes from. For me on my side as the ACP coordinator, I want to keep up to date with all the medications that's happening. I know recently there's new news of adding, another medication to the list. So I know back next month in May, there's another City of Hope that's going to be talking about medication. So sign up for that. Be aware of that some patients, even though we know the criteria is less than 6 months to live, not everybody has a crystal ball. And so we have had patients over 6 months that has the prescription, and I've had to call them and says, you know what, only one patient right now that your prescription has expired. So, for us in our, 2019, we started 2020, the beginning part, we're like, yes, process is done. Let's get the prescription out. Right now I kind of hold back a little bit just because I've had some outliers, and I've always checked in with the patient, says, hey, you finished that process now. You tell me, do you want the medication now? Do you want to wait until you have a specific date or a specific timeline, and then we'll move forward. So I actually have about 3 patients on that. They've finished the process, but they haven't reached out back to say, Michelle, I want to move forward with the medication. I mentioned about the education for the compounded medication is very important. And yes, for us at HPH, we have switched over to DDMA. Hard copy logistics, pharmacy has to receive a hard copy of the prescription. If they don't have that hard copy, they cannot compound the medication. We also give them a heads up, either a phone call and send them a fax of the prescription. We also tell them, hey, we put on our prescription who is going to pick up the medication if it's on Oahu, because the pharmacy would like to know who as well. And they also like to have the phone number, because sometimes the patients may not pick up. So they like to have that support person of who to call. And most of the time for us, it's many of patients do pay out of pocket, and it's $425 to $450 for the compounded medication. Elex RX will FedEx the prescription outer island. So I always tell the patients outer island, expect a 24-hour window, and they need a person at their house to be present, an adult person, to sign off the paperwork, not just drop it on your doorstep and who knows who's going to pick it up. I always educate to make sure about safekeeping. One of my Maui patients last week, I called and I says, hey, did you get the medication? They're like, oh yeah, we got the medication. And we put it away in the fridge. And I was like, I don't think it's mentioned put it away in the fridge. You have to put it in a dry stored area. And she's like, oh shucks, I thought I heard that. So it's always go when you check back with them, make sure they got the medication, make sure they know where to put the medication. We've also had a family who they totally forgot on the day of because they're all anxious and everybody's like, whoa, they actually forgot where they store the medication. They found it later and the patient did take the medication, but that there was a period of stress. It was like, oh my goodness, where did we hide that medication? They told us to put it away safely and we totally forgot. So just tell your families, know where you put it as well. And then medication instructions again. This is just a workflow. I can't take credit for it. It's one of my coworkers that's really good about these spreadsheets and Excels and this workflow. So basically, it kind of and the staff uses this quite a lot. You know, they'll go through the steps, and if I'm going to a consultant physician, or the person makes the first oral request or the patient request, then they just click into the box and it gives them directions. So the next slide shows an example of that. Next slide. So this is an example of the tending physician that Laura spoke about. So it tells the physician and the staff, because most of the time it's the staff that's helping them, such as a social worker, nurse navigator. Hey, it's due in 30 days. Make sure you send A, B, and C. Make sure here's the mail it to the Department of Health. Give them the address right there. Here's a link to the Department of Health with the form that Laura needs. And then also for us on our side, we also scan it into our medical records. And then again, for us to keep track of all the forms, we title it so we can find it easily to send to the Department of Health. So here's Judy. I'm going to quickly share about Judy's story, what she taught us, and she has given us permission to use her picture as well. So Judy, back in 2018, the end of 2018, she beautiful. You could see from her face and her laugh, she's a beautiful person, and her love was Hawaii. She came from Connecticut or East Coast, and she loves her friends, good wine, good food. She was a chef. She loved music. And she had metastatic cancer that eroded basically close to her heart and to her left side of her chest wall, and where no surgery could be done. She did go to the mainland to try to do what was needed, but unfortunately could not have any operations for that. So when she came to her PCP, she said to her PCP, you know what, I'm interested in medical aid in dying. And the reason she was interested is because her mom died of cancer like over 30 plus years ago. And then her mom actually wanted this. And at that time, it was not the law. And when she was dying, she had requested her daughter to say, I want this, but her daughter couldn't do it. And Judy's third husband also passed away with cancer. So she's had this, she's been around death and she knows what it is. So she did join Compassion and Choice and to learn about it. And so for us, when she came to her PCP says, you know, Judy, I'm not very comfortable. And he was honest. I'm not really comfortable about doing medical aid in dying, but let me refer you. Let's refer you to palliative care. And that's what we did. So when she came to palliative care, we basically had her role for her on her side was she had to do homework on all the hospices that she wanted to join when it was her time. She got us involved in getting the chaplain because spirituality is very important. So we had our inpatient chaplain come to the outpatient and had meetings with her. She went back to her PCP and spoke about her process, what was going through. Her homework for herself was just journaling about this process and sharing it with us, as well as she got educated from the palliative care about end of life on death doulas. And so on she did get a death doula, and she had 2 death doulas there on her day of her death. And she also did her UH Will Body program, as well as she wrote a beautiful, her self-owned self-obituary. So if you look out her name, Judy Brown, and you'll see what a beautiful obituary she wrote. And for us on our end, what we had to do also for her, she was in assisted living facility. And basically she wasn't sure if they would have her take the medication down the road. This is now 3 years later, down the road, 2020. she ended up moving forward with the process. 2019, she learned about it. 2020, she was okay. 2000, and then 2020, I'm sorry, she was declining. And then that she's like, I think I'm going to move forward. So, but our homework for the last 2 years was working with the nursing, the assisted independent nursing assisted facility. And we did education with them and say, hey, would you allow Judy to move forward with this? And they were absolutely on board. And so for us, for HPHNR, and was coordinating with them and giving them the education. They went to their ethics committee, they had meetings with their staff, and then vice versa, we had education. We had like 3 meetings with them, not only on the education, we also went through the process because this was through COVID times. They did so much. They had through COVID times, they were able to facilitate her doctor being with her friends being with her, and the staff that she knew so well at the hospices as well as living there. They were able to coordinate that as well. So so she taught us a lot within her time that we knew her requesting medical aid in dying. So from her, she's like, just explore what it is. Don't be scared of exploring about dying and not be afraid. Thank you.
Hello, my name is Erin. I'm here today to kind of talk about the continuum of care and what that looks like for patients who are entering hospice and also receiving supportive care, palliative care, concurrent care as well. So when we receive referrals for hospice, obviously we're going to be having the normal that you're all very well aware of. So whether that's the medical equipment, prescriptions related to the hospice diagnosis, and really also providing that care wherever the patient is located. So whether that is at home or a facility or a foster home. We have the IDT team assigned. So we have the MD, the RN case manager, the nurse's aide, the social worker, the chaplain, bereavement. And then of course, the first thing we want to do for any of our hospice patients is address pain and symptom management and really dive into the psychosocial aspect of it and see if there are any spiritual needs of the patient at all. And we also want to include our hospice staff as well. So respecting personal beliefs, I think, was something that Michelle and Jodi said as well. Whether a team is comfortable with that particular situation or not, we want to make sure that we're surrounding the patient with a care team that is going to be able to be there and that everybody's comfortable in moving forward. So as we can see from the presentations from Jodi and Michelle, the Kaiser and HPH system has definitely allowed so much structure and protocol for us to follow. And it has been a great resource. We have challenges, of course, when patients are not necessarily inherited from the Kaiser or the HPH system. So when they're actively in the community, and perhaps it's just a hospice patient that we already have on board, and then they voice that this is something they want to pursue. So I think those present different challenges that maybe aren't necessarily talked about currently. And some of those are going to be, they may have been with a particular physician for 20, 30, 40 years, and they really want their physician to be their attending physician for this. So trying to reach out to them, see where that community physician is and what their thoughts are and their feedback is also a challenge because as we know, this is somewhat new to Hawaii. So of course the physicians are, there's a little bit of education and hesitancy. So again, we want to respect all thoughts and opinions involved. So the attending consulting MD, the family dynamics, of course, I think as we kind of continuously hear, the social workers are really one of the biggest support systems, and the family dynamics are often very, very intense because, where a person is on this, their personal belief system for this definitely is going to contribute to the situation. So having care plan meetings, family meetings, the patient also, where are they? Are they in a facility? Because there's a lot of nursing facilities, a lot of foster homes that this is not part of their protocol, and they will not allow it to happen there. So I think that's also another challenge. And what these items are presenting is going to be access and time delay. So as we heard, this is a minimum of a 20-day process if you had everything in place. And when those items aren't in place, you're having to look to different resources, whether that be compassionate choices to kind of just mentor and educate. But also the average life expectancy for hospice patients across the nation is 10 days. So often you're going to have patients who are going to voice that this is something they want to pursue and may not be eligible. And then of course they have to be able to self-administer and those other items that are part of the legal aspect of it. So the solutions definitely work with your community partners. I'm always hoping that they're part of the HPH system or Kaiser system when we do get that, because it again, having a navigator in place makes a huge difference. And then compassion and choices definitely is a huge aspect and an education piece for us. And then trying to continue to do staff education as well, because every single patient and every single employee that you have is going to have different beliefs as well. And then this has changed quite a bit in the last 2 years as well. So just making sure we try to stay updated on that is a challenge. So what does this look like in the home or the foster home or the facility setting? So, again, wherever a patient is where we're going to follow them. So some of the challenges have been, where they're located. And we're going to really just be treating this as if they are any other hospice patient, except that often it's scheduled. So we kind of just like when we walked through with Jodi and Michelle, we're looking at the timeline. Do they have a specific date or a specific time? And as we kind of heard with the stories before, some patients are very, very particular. They have it down, some down to a minute that they want this to be done. And have, whether it be the death doulas involved and having life celebrations and having, we've seen ones where they have, flowers brought in, champagne, poo-poos, and just really, truly having one of them called it like a bon voyage party. And so very, very planned. And again, just being neutral and respecting everyone's personal beliefs and how and what they want this to look like. We want to also make sure that if we're getting it as a community referral, that of course, all of the regular items are in place. So for the POLS, the Advanced Healthcare Directive, and then because of the unique challenges with the social aspect of it, pre and post bereavement as well. And then when the family dynamics come in, also, you're going to have maybe patients who do want to tell certain individuals in their family and then may not want to tell others. And so we have to respect the HIPAA piece of that, and it's part of the application. So if they do not want to tell their son or their daughter or their husband or their wife, we have to respect that. And just that's also part of it. The other challenges, I think more recently that has been popping up is going to be if they are in a foster home and if Medicaid is their payer, and also if they have a certain particular case management agency, again, whether their beliefs or their stance, and if we have to have a transfer. So we have instances where maybe a foster home is not going to accept it. And so they're saying that the patient has to be transferred if they choose to do this. So whether it's the day before that they plan to do it, and then also some case management agencies may have a different stance on it if it's something that they are going to still participate in as being their case management agency, and then may refer out to others. So these are some of the challenges, as well as if we are then looking at a transfer into perhaps like a SNF or an inpatient facility setting, there's challenges as well with those as to the attending physician and the rights they have there, and whether or not the facility is okay with this sort of decision. And I think it's really, really important for us to be just completely transparent as much as possible for all of those involved, so that we can continuously have this open dialogue and really talk about this together. And that's it for me. Thank you.
So my job is easy because I get to work with all these fabulous people. Part of what I do is really focus on the education. And if I've said it once, I probably said it a dozen times, that we always need to remember that our providers in many cases might be having the first request or the first conversation about medical aid in dying. And that takes time. It takes time for the staff to think through their own, as you heard, their own belief systems. It's what we've seen are these beautiful stories of being able to help people with the decisions that they've made and the way that they want their life to proceed because they have a terminal condition. And the education that we're doing is in really two major areas. One, we focus on the legislative changes that need to be made based on Laura Arcibal's data. Okay, the Department of Health data. But, and actually in taking a look at what we know from the experiences of Kaiser and Hawaii Pacific Health and talking to the independent physicians who have participated and what the barriers have been. So we really continue to take a look at what those Department of Health recommendations are and how do we rally and educate to be able to support those changes from happening or to happen. Including APRNs as a provider type will really help us with the requests that are particularly on neighbor islands where we know that we already have physician shortages. Taking a look at being able to waive the waiting period if we know that that patient will not make it through the 20 days. And at some point we may want to really look at should the waiting period be reduced from 20 to 15 days. So that is definitely, those are all data-driven decisions that we really want to make sure that we keep out in front and say, how do we do things better? The other thing that I do is help to set up clinical education. And all the people that you have seen talk today are on my list of people that I tap regularly. And we have a number of physicians that are telling their stories now, which is really, really helpful. We have people that are willing to be resources so that it is education from maybe a continuing education webinar as much as a mentorship of one physician being willing to mentor another physician through the process. But the education is really across the whole gambit with physicians, psychologists, nurses, licensed social workers, and really making sure that we've got people that are willing to tell those stories to their peers and bringing them on board. Partnering with organizations. So certainly all of the major healthcare systems, but also doing things with the Hawaii ANA, the Nursing Association, and the social worker associations, so that we really have that ability to help people just better understand what this law is all about, and realizing that just we want to be able to help the patients in need. So we've done some continuing education sessions. We did 2 last year, and we've done 5 so far this year, and 1 more in June. And thank you to this team that I pulled together to help with Kōkua Mau's request. Thank you, Erin, for coming in at the last minute. It's wonderful. To help with those continuing education sessions. One focused on mental health and really being able to say, what is that whole aspect of this particular law, which is so unique to Hawaii. A couple of them were specifically on nurse navigators. A couple of them were more general, but really just making sure that we've got all those opportunities for people to learn. I think that's my last one. Next slide. Yeah, so here are the Compassion and Choices resources. Just want to make sure you always have those handy if you are interested in learning, or if you find a provider that is really starting to go down this path with a patient. There's the doc-to-doc line so that mentoring can help and happen in a fairly quick way. So I will turn it back to Hope and Jeanette for answering questions.
First of all, thank you so much to all of our presenters. If we were in public, we would be clapping for you. Thank you very much for, you sharing your professional and of course personal experiences with this. So thank you very much. So the idea now is that people can ask some questions. So I'm going to start first of all with Linda Dullen's question, which was, does anybody discuss the cost of the medication and, the insurance benefits with patients and family? I think my question too is, do any insurance companies cover this? Michelle, you want to take that one?
Sure. A lot of our Medicare patients, it does not cover it. We've worked with other insurance companies too. Usually the social worker, again, is the one that's calling the patient's insurance companies to follow up on that. And we have not. I know Jodi mentioned about the Medicaid program. They do cover it, and Kaiser has a different part for their patients. But a lot of our patients have to pay out of pocket for it. It's a $425 for the compounded medication, plus or minus your FedEx fees, if they have to go out to island. We had in Kauai one pharmacy that has now been taken over by CVS, and they used to do it, and the medication was around $750 because it was a private pharmacy. But unfortunately, they closed, and that CVS has taken it. So there's nobody in Kauai now. So Elex RX is the one that we go to for all of our compounded medication prescriptions.
So at Kaiser, part of our process is once Susan or I meet with the patient, one of our next steps is to send an email to our pharmacy administration, and then they actually do the research based on the patient's plan, and then they message our financial counselors, and one of our financial counselors calls the patient or family to let them know the cost, so they know right up front, what will be involved. But I've seen it vary from $0 to, I think the highest rate it's like $200 something at Kaiser. But I've seen some plans are no cost. So it just depends on your plan.
Well, thank you. So I had a couple questions while we see if people have other ones. I'll ask my first question. I remember hearing a physician in Oregon say that this has been available for 20 plus years, that the vast majority of people just wanted information. And then it was sort of like a giant funnel. Started like lots of people were interested, and then it actually were very few people that wanted to follow through. And then that feeds into the next question, was the reasons that you find people like are interested in pursuing this option. So maybe we could start with Jodi.
Sure. So for our patients, I think the biggest reason why they want to access this option is just to know that they have the option and they have the choice. As time goes along, as they become more debilitated and less independent. And I think sometimes just having the medication is palliative in itself, and knowing it's there if I need it. But most of them are on hospice, and hospice has been so wonderful in supporting them. So we do see a lot of folks that, they don't use it. They don't use the medication. So it's usually just, knowing they have the option, and they're worried about suffering and pain, as well, understandably, and just, the unknown and being able to have some sense of control over that.
And Jodi, when you say a lot, is it like 50% don't, or what do you see?
So maybe it's even more than that don't use it. It's maybe a little more than 50%, I would say.
I was just going to add, when we look at the data from Laura, Arcibal, as well as what we've seen across with Hawaii Pacific Health, Independence, and Jodi and Kaiser, it's about a third overall that get the medication and then choose not to use it. So that's very similar to what you heard with Oregon. It really is about people just feeling like they have that control over their destiny. Mm-hmm.
Great. Yeah, I was going to ask you and Erin too later. So thank you, Caryn. I appreciate that feedback. And Michelle, is your experience similar?
Yeah, a lot of people, I mean, initially they don't want to be a burden to their family. So really exploring what does a burden mean to you, for them to you, and vice versa. Talk to their family, are you a burden, you know? So that's very important. And that comes up quite a lot. A lot of them is the quality of life. For example, I had an ALS patient in Hawaii, and he was like, once, Michelle, I can't swallow. It takes me an hour to eat right now. You know, when I did the Zoom with him, he had to really, we talked for an hour, but he had to really hold himself and hold his head up, right? And his caregiver had to be there. He says once that's declining, and he had a timeline earlier than when he passed with the medical aid and dying. But basically with his family was in Oahu, and he lived in Kauai because he wanted to spare them seeing his debilitating effects of ALS. He had a huge family, supportive, beautiful, but he didn't want them to see what he was going through every day with his bowels and incontinence. And so he had a caregiver who was wonderful, and he was by his side all the time. And that's the one I communicated a lot with. And so for him, he said, Michelle, okay, I got this date. And then he's like, and then I was like, I check in with them, and they're like, no, guess what? My son wants to get married, and they're going to come to Kauai. So we're going to have the wedding at the house. Okay. So we have a plan. And then the wedding got delayed, or COVID happened, COVID. So different things have happened throughout their thing. But then eventually he did move forward after the wedding happened. His goal was to get his house and his yard clean. So he did all that, get the renovations done. And once he finished everything, then he had said, okay, I am ready to move forward. And he had all of his family was there. His grandchildren was there. He had a 3-day ceremony. I called them. It was in Toronto in March. I called the family. I called them. And they're like, Michelle, we're going forward. And there'd be good communication back and forth. With the rain through in March, you know how it was raining in Kauai a lot. But everything went smooth. And so for him, it was just quality of life was really important to him. And then regarding more specifically about the stats, just like what Caryn said, for us, we've had 33% of our patients have had the prescriptions. And out of those people who initially inquired, 20% have taken the medication. So Caryn is right off on the bat, yeah.
We expect Caryn to be right on. Thank you. Mm-hmm. So actually a bunch of other questions have come up. I just want to check in case Erin had something to add before we move on to some other topics.
No, same thing as Jodi and Michelle. So definitely the quality of life and the physical decline markers are usually what they are going to be identifying as when and if they want to pursue this and contributing to it.
So one question, do you need to be a permanent resident in Hawaii to be allowed to have this option? People are nodding, right? Caryn, you want to take that one? Laura, how about Laura? Laura, can you take that one? Department of Health?
That's the law it just says that you must be a resident in the state of Hawaii. So that's it. And that can be open to interpretation. I understand that. And it's up to the provider, really. It's provider judgment in knowing that the patient is a resident in the state of Hawaii.
Okay, thank you. So question, Erin's question is, Erin, are folks enrolling in hospice prior to requesting medical aid in dying, or the other way around?
It's going to be both. So we may have patients that are already enrolled in hospice and then making the request, or we're going to have patients that, whether they're meeting with Jodi or Michelle and then kind of starting that process and then getting referred into hospice. And then also, I think the other aspect of it being that Hawaii is unique as well, is that we have, you know, supportive care programs. So people can be choosing to do palliative programs, still be seeking life prolonging aggressive treatments like chemo or something like that. So they wouldn't necessarily qualify for hospice. And so I think sometimes that may be something that, you know, we wouldn't necessarily think about, because it would be almost, you know, counterintuitive that you're going to be taking this medication, but I'm going to be doing chemo for the rest of the month until I get it. But there are instances like that. And so we would get them both ways.
Jodi and Michelle, do you both see it that way? That there's,
Honestly,
do people do hospice first? And
we do the education right up front, and honestly, I tell them they have to do hospice. I said, I'm not moving forward. I'm tell them, you're not moving forward with us if you don't enroll in hospice. You need hospice for A, B, and C. They're the best people to be on board when your loved one is dying. They're there, whether they're in a room with you when you're taking the medication, if they're just sitting outside in the street. I mean, they're awesome. I mean, kudos to you guys. I mean, and I tell that patients and their family, you better enroll in hospice. I'm sorry, because I'm not going to feel comfortable. My doctor's not going to feel about, you got to do it. That's what I tell them.
Yeah, I guess we're similar to, but we do have patients that are still getting chemo, and then they're starting to pursue the process, you know, in oncology. But yeah, I mean, we strongly encourage it right from the start. Just, you know, you should do this hand in hand, and have the hospice team behind you.
okay, thank you. Another question. If a patient goes through the process and is accepted, what is the minimum number of days that a person can perhaps wait until medical aid in dying? It looks like there's a verb missing there. Can wait until a person can get medical aid in dying. It's 20 days, right?
Right.
Laura?
So the minimum of 20 days between the first and second oral request. And then there's also the provider examinations and evaluations at the end. So once the last provider completes their examination, then the patient is considered qualified. And so not less than 48 hours have to pass between the date of the receipt of the qualified patient's written requests and then not less than 20 days between the first and oral. Once those two conditions are met, then the prescription can be written. I think that's a really excellent question, because we track that. I look at that. I look at the dates of the consulting and the mental health provider, and I make sure that that 48-hour period is there, and that the qualified patient's written request is not sooner dated than that. So ultimately, it could be at minimum 22 days. And so
Got it.
Is by at least the 22-day mark or the 23-day mark. But from the data I shared earlier, you're seeing about 35 days is the average for 2019 and 45 days for the 2020 data. And that is based on those dates.
If I can just add a comment, therein lies why we continue to do education. Because those time periods are confusing. And if a physician is maybe doing, having one patient even a year, it's always going back to, okay, what's that time frame? What's the 2 days? What's the 20 days? What's the 48 hours? And it's complicated, but it's complicated for a reason. So thank you to Laura and the Department of Health for doing such a great job on those forms. They're really, really helpful. And the timeline.
So that timeline eligibility process is really key, because it breaks down the process from day zero, when the patient comes in to request that first oral request, and then what happens during that time period and what the providers are doing and so forth. And the waiting period is a question that we get quite often. I do get calls for that clarification. So thank you so much for that question, Clive.
Well, he has a second part of the question, which is also interesting. How long can a patient defer and not take? In other words, if time goes so long, does the patient ever come off of medical aid in dying by default and would then need to reapply?
Well, you know, we track up until the patient receives the prescription, and that's the data that we collect. We don't know. So for example, if a provider is not informed of the patient's death, that patient could look outstanding in terms of the data that we collect. So the follow-up form is the report number 2. If I don't receive that, then that patient on my record looks out still alive in a sense, or still has that prescription. And that's where the law ends in terms of that process. So good.
You know, medicine is not a perfect science, right? And the ability for a physician to determine 6 months or less to live, they're very good at that, but it's not an exact science. And so, and some patients just live longer. As I understand it, and Laura, correct me, people aren't quote unquote reapplying. They don't need to start the process over again. It's really just a part of now they were determined and are terminal, but they might just be living a little bit longer than that 6 months. Michelle, I see you nodding. Would you, anything else to add?
Yes, that's a common question that many of our patients do ask us, because they don't have a timeline, they don't have a date set, and they're like, and especially now, Laura, you'll see your numbers get a little bit longer because I am delaying their prescription time. Because I'm saying, you know, if you're not ready and to have this medication right now and you have a timeline and you have to pay the $400, for us, for them, it's $425 minimum. Absolutely, we can wait and you tell us. So we don't have to start that process over again. Our oncologists or PCPs or providers are watching them. If they lose their capacity, obviously they're not eligible anymore. You know, a lot of our patients, they want to move forward with taking the medical aiding, but what we see is they've declined so fast, they're not able to take it. So yeah, we don't start that process over again. We just keep evaluating them.
And at Kaiser, you know, what we've decided is that, so Susan and I will continue to monitor the patient and the case, and, you know, keep the attending provider informed. And if the attending provider feels that they need to meet with the patient again, or if they should meet with the mental health provider again, then they'll indicate that. But otherwise, yeah, it could be months later that they get the medication, or they have the medication and haven't taken it for months too.
Okay, thank you. All good questions. Another question, in the event that a patient chooses not to take the medication, how is that medication accounted for and destroyed?
I guess we all can answer it too. Well, at Kaiser, you know, part of the process is they meet with our oncology pharmacist actually to go over the medications. And at the time they're given an envelope that's addressed to a federal repository. So, and with given the instructions that if it isn't taken, you know, you or family should send this in and return it.
Yeah, the thing that I would,
the family themselves.
Yeah, I would offer that these people are really sick. They have a lot of medications in their household. This is one more. So that it's a bigger picture question about how all the meds get returned or are destroyed, not just for this one particular med, because they usually have quite a few that are already in their house.
Another question from Clive about the prescriptions. Is there a shelf life on the prescription? So if a patient gets the drug May 1st, 2021, how long before it expires?
I can answer that question. By law, the pharmacist has to put for the compounded medication 6 months expiration. The reality, the medication have patients used the medications beyond 6 months? Yes. Have we at HPH had a patient take the prescription longer than 6 months? Yes. 8 months was our longest patient, and that family did talk to the pharmacist. Remember, the medications are a lot. They're very toxic. It's to end your life, right? Maximum doses of digoxin, diazepam, morphine, and amitriptyline. So like taking your expired Tylenol that's sitting in your cupboard that you all know you do, same thing. But me as a professional, my duty is to tell that patient, hey, your medication has expired, and I have to let you know that you are welcome to get a new prescription from your provider, your attending provider, and that's a choice that you give them. But so yeah.
Okay, great. So another long-term Kōkua Mau member and supporter, Melissa Bojorquez, asks, if the individual expires as a result of medical aid in dying, is it indicated as cause of death on the medical record or the death certificate? And has there been any negative ramifications based on life insurance benefits for survivors or beneficiaries?
That's a Laura's answer.
She's got this answer down.
Answer this, but I will answer it, yes, because the law requires that the provider put the underlying illness as the cause of death. So not suicide or some other option. It's the underlying illness. So in this case, most often patients are suffering from cancer or some other illness. That is what goes on the certificate, the death certificate.
And there is not impact to life insurance.
Not that and that's not something that the Department of Health collects as well. Right. We wouldn't know that, but we do know that, that's not something that we know about. I think that happens, if it happens, we don't know.
Mm-hmm.
So again, the law
according
is really
to the law,
designed.
It's not supposed to, right?
Well, right, because the law is helping people that are already terminal. Their illnesses, they are going to die. This just helps them really design how they want to die and when they want to die. But their illness is going to kill them. And so that's why it's really important that the death certificate is really writing the underlying cause of death, which was the ALS, cancers. Those are the very important things to make sure that the documentation is correct. Mm-hmm.
Great. So I don't see any more questions. We can give people a moment to see if there is anything else. If any of our fabulous speakers have anything else that they'd like to share. Was that your hand being raised there, Caryn?
Yes,
I
just want to go back to the health plan coverage question. That patients should really be having that conversation with their health plan. So if you really think about what is happening in this process, it's a basic physician office visit. So the only thing that really is a coverage question would be the prescription. And as we understand from the last 2 years, the health plans will cover the prescription. Now, what happens is sometimes the pharmacist will say, I'm going to give it to you, and it would be your job to maybe submit it to your insurance and get reimbursed or something like that. And that's probably why things are appearing like the health plans aren't covering it. But when the law was passed, the health plans were all on board with covering the aspects of medical aid in dying. So I would just encourage people to talk to their health plan.
And I know I could speak for Jake in the last conference or webinar that he presented. His pharmacist does reach out to the patient's health insurance before they move on to getting the patient's credit card. So he does do that as well. Yeah.
Okay, any other last minute comments or something that folks would like to share before we turn off the recording? Is there a financial aid plan for those who do not have insurance?
At Kaiser, we have a medical financial assistance program, but it's for any patient depending on your income. So theoretically, a patient could be qualified for that and have no charge for these medications.
Great. Well, such a thank you so much for all of your very insightful and heartfelt comments and excellent presentation. You guys did such a good job of pulling it all together, and clearly there's still a lot of interest in our community. So thank you very much to everyone for coming. Yeah, I wish we could all be in person and chat, but maybe that's sometime in the future. But thank you very much, everyone, for spending your time.